Hello everyone, my name is Manreet Kanwar, and over the next few minutes I will be talking about a project we recently undertook as part of our ongoing efforts with the Cardiogenic Shock Working Group in using artificial intelligence and machine learning to phenotype patients presenting with cardiogenic shock. These are our financial disclosures. This audience is probably well aware of the fact that in the last 20 years we have failed to make meaningful progress in cardiogenic shock. Despite advances in our use of temporary mechanical circulatory support devices, cardiogenic shock continues to be a highly lethal syndrome with a substantial short-term mortality ranging from 35% to 50%. Now, part of the problem is that our previous trials have traditionally focused in acute MI-related shock, and beyond that, there is lack of large contemporary databases for patients presenting with all other etiologies of cardiogenic shock. Moreover, we tend to apply fairly specific but rather arbitrary cutoffs to what we believe should be the biomarkers of progression of cardiogenic shock, thereby introducing bias and failing to capture the full variability of patient profiles. About 2 years ago, SKY introduced the staging of cardiogenic shock ranging from A, at risk, through E, at extremis, in an attempt to start looking at patients at presentation based on how sick they were and not just why they were there. Over the next few minutes, I will be presenting our paper on behalf of Cardiogenic Shock Working Group, where we used machine learning to further phenotype patient characteristics presenting in cardiogenic shock. We did this analysis with the hope to ascertain if machine learning algorithms could mathematically reduce routine clinical informations to specific reproducible phenotypes of cardiogenic shock, which would then further have clinical applicability. And our hope was that in doing that, we will further our understanding of shock physiology and eventually use this approach to further risk stratify these patients. We included nearly 2,000 patients from 2 cohorts. The first cohort was our own Cardiogenic Shock Working Group registry, which includes patients from both acute MI and other etiologies of cardiogenic shock. The second registry we used to validate our phenotypes was the Danish Retroshock registry, which is a registry of patients with acute MI-related cardiogenic. The Cardiogenic Shock Workgroup registry started initially at 5 US clinical sites, which then extended to 8, to more recently over 20 US clinical sites that enter data from all-cause cardiogenic shock into this database. This particular analysis was done from our initial version data, which was collected from 2016 to 2018, retrospectively for patients presenting with cardiogenic shock. The Danish registry is similarly a retrospective registry from 2 Danish tertiary care centers and focusing specifically on patients presenting with acute MI causing cardiogenic shock. One way of defining machine learning is that this is a mechanism whereby we use artificial intelligence in getting computers to act without necessarily explicitly programming them. The action could be making a prediction, for example, who is more likely to die presenting with a certain specific scenario, to classify a phenotype or a genotype, which is what we attempted to do in this particular paper, find patterns within very large data sets, to then make inferences upon them, etc., etc. Now, machine learning can be broadly classified into 2 types, supervised and unsupervised learning, shown in the cartoon here. For this analysis, we used k-means clustering, which is one of the most common unsupervised algorithms that iteratively tries to partition the data into distinct and non-overlapping subgroups called clusters, whereas in each cluster, a single data point belongs to only one group. We took our nearly 2,000 patient data set and divided into derivation cohort, which included patients presenting with acute MI from the Cardiogenic Shock Workgroup, which was about 410 patients. We then validated it within the Cardiogenic Shock Workgroup but patients presenting with non-AMI cardiogenic shock, which was about 480 patients, and then also subsequently in the Danish registry, which was about 1,069 patients presenting with AMI cardiogenic shock. Lastly, patients with each phenotype were further categorized by their SCAI staging. Now, this is a fairly busy slide going over the key baseline features, which I will summarize. The acute MI cohort from both the cardiogenic shock workgroup as well as the Danish registry were similar on various clinical variables, but differed in age and treatment strategy, especially in the use of temporary mechanical circulatory support devices. On the other side, the cardiogenic shock workgroup non-AMI cohort differed from the MI cohort in several clinical features, including younger age, higher body weight, more severe kidney and liver injury, as well as lower lactate levels. We deployed semi-supervised consensus k-means clustering on the 6 identified variables with highest predictive value for mortality. These included features such as GFR, serum bicarb, lactate, ALT, platelet count, serum creatinine, WBC count, etc. Consensus k-means clustering in the cardiogenic shock workgroup MI derivation cohort identified 3 as the optimal number of clusters based on calculated silhouette scores, cluster consensus, and other metrics. These clusters demonstrated important differences beyond the variables used to design them, suggesting that the clustering algorithm had successfully identified these 3 distinct clusters, which would then act as distinct clinical phenotypes. On the basis of their clinical characteristics, we labeled the 3 phenotypes as non-congested or phenotype 1, cardiorenal shock as phenotype 2, and cardiometabolic shock as phenotype 3. The 3 phenotypes, as you can see, differed from one another on various demographic and clinical parameters. We then used radar plots, shown on the left, to display the deviation of metabolic and hemodynamic values from the mean value, and chord plots to reveal the source of phenotype differences. The non-congested phenotypes exhibited a lower heart rate, filling pressures, and a higher blood pressure relative to other phenotypes, representing a relatively stable profile of a non-congested patient with cardiogenic shock. In contrast, patients in the cardiorenal shock of phenotype 2 were older with multiple comorbidities. They exhibited a lower heart rate, an elevated wedge pressure, elevated CVP, a lower GFR, suggesting renal involvement from shock. Lastly, the patients in the cardiometabolic shock workgroup exhibited elevated lactate, ALT, heart rate, right atrial pressure, along with a lower blood pressure, cardiac power output, and index. This suggested a multi-organ involvement featured by transaminases and lactic acidosis in patients with, as shown in this figure here. In the green box is the non-congested shock, which is associated with the lowest mortality across all 3 of the cohorts, followed by, in red, is the cardiorenal shock, which is associated with the higher mortality compared to phenotype 1 across all 3 across all 3 cohorts. And lastly is the cardiometabolic shock, which is associated by far with the highest mortality, regardless of whether it was in the derivation cohort or in the validation cohort, including patients both with AMI and non-ischemic heart failure. Lastly, we compare the distribution of each phenotype's patient with regard to their most severe SCAI shock staging encountered during the hospital stay. The risk of developing stage D or E, which is advanced SCAI staging shock, during the hospital stay was lowest in phenotype 1 and highest in phenotype 3 for patients with both cardiogenic shock related to MI as well as cardiogenic shock related to acute and chronic decompensated heart failure. Within each phenotype, the SCAI staging further stratified mortality. Similarly, within each SCAI staging, as shown here, the 3 phenotypes further stratified mortality. In conclusion, we were able to show an unbiased machine learning approach to identify 3 distinct phenotypes in cardiogenic shock, which were associated with clinical outcomes, i.e. mortality. We were also able to show that the hemometabolic shock is associated with highest mortality and stratified across SCAI staging. We feel that approach such as ours can help improve risk stratification by defining subsets of mortality risk within the SCAI staging, and eventually enhance clinical trial enrollment by developing strategies tailored to each shock phenotype rather than the one-size-fits-all solution we currently use. Our study has several limitations, including being derived from retrospective data sources, using limited number of patients and clinical variables. We have to remember that machine learning algorithms tend to perform better on larger data sets, and that sample size may limit the complexity of the derived cluster model. We also did not include long-term outcomes in our analyses, but we hope to correct many of these limitations with our ongoing data collection, which we call version 2.0 data from year 2019 onwards. Thank you for your time.